Normally, you might be used to thinking about a patient going in to see the doctor or going into the hospital to get a particular service or a procedure. And all of that seems rather transactional. I went in, I got something done, and I came back home, and that was the end of it. Population health is when we take some responsibility for managing the health of our patients from birth to death, really, and to manage their cost, the quality, and the experience of care.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Raja School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today, we invite Dr. Naveen Raja from UCLA to join us for the Business of Healthcare podcast. Our topic today is population health. Dr. Raja is board certified in rheumatology and clinical informatics and has over 17 years of clinical practice experience in rheumatology and internal medicine. He works within academic, nonprofit, managed care, and private practice environments. He currently serves as the medical director for Accountable Care at the University of California, Los Angeles. His focus is on driving and supporting strategies and programs related to population health. Welcome to the podcast, Naveen.
It's great to be here, Bob. Thank you for having me.
Just as important, Dr. Raja is a member of the Alliance for Physician Leadership program at the university, where we collaborate and educate top physician leaders to move forward with significant changes in healthcare. So for the benefit of our listeners, how do you define population health?
Population health is a way to manage populations under a health system or a doctor's practice. So normally you might be used to thinking about a patient going in to see the doctor or going into the hospital to get a particular service or a procedure. And all of that seems rather transactional. I went in, I got something done, and I came back home, and that was the end of it. Population health is when we take some responsibility for managing the health of our patients from birth to death, really, and to manage their cost, the quality, and the experience of care.
Well, we heard the term a lot called value-based pricing, value-based care. We hear that a lot nowadays. How does value-based fit into the population health definition?
They're almost synonymous. Value-based care refers to providing value to the patient when they come into the door. So if a patient comes in to see me for diabetes, and I just give them a medication and I say, bye, they may not take the medication. They may not understand the medication. They may not follow a diet. Now, if I say my responsibility is not to prescribe medication, but my responsibility is to get their diabetes better, then I'll do more things, right? I will educate them about their diabetes. I will ask them about their diet. I'll ask them about their exercise. I will ask them about their social and cultural environment. So taking the whole patient into account and delivering an outcome, the outcome is called value. So delivering an outcome rather than just a transaction is considered value-based care.
Okay, so I'm not a physician, so I try to stand in the shoes of one. And if I thought I get paid every time I see somebody, fee for service, I'd like you to come back as much as possible, and I can charge you every time you come back. And by the way, why don't you come back again in 2 weeks and we'll look at it again? Is that mentality, fee for service, does it get eradicated and eliminated with this value-based approach?
Yes, it would. Most physicians do the right thing. See patients only as needed. But the incentives are not aligned with that. The incentives are aligned, as you said, for providing more and more services because you get paid by the number of services you render in a fee-for-service environment. Fee-for-service is the current dominant environment. But we're moving to a different model, and there are many such models coming up, where the doctors and the hospitals get paid for delivering an outcome, as I said. The outcome could be cost, could be quality, could be patient experience.
Would you say that population health is a new concept? What is the history and the background? How did it come to be?
Population health has been around for a very long time, decades. The movement to build alternative payment models where we actually pay the doctors and the health systems differently, that's much more recent. And that may have its origin, in the last few decades. And in the last decade or so, there have been more and more of those models, so people are hearing about this more.
Okay, would you say that population health and public health are similar, or are they different?
Public health and population health at one level are synonymous in the sense that if you're talking about the population of a city, if you're talking about the population of a county, then you're talking really about public health. But when you say in a health system, in a doctor's office, when you're referring to all of the patients in aggregate that the health system is responsible for or the doctor is responsible for, here we're defining the population of a practice.
Okay, that's a very good clarification. So that makes a lot of sense when I think of it that from that perspective. I might identify a population of teachers. I might identify a population of policemen. I might identify a population, and then I would be addressing that population with the right perspective of taking care of them, as you said.
Yes, or it could be a mixture of all of the occupations that come to see you in your practice if you're a doctor or a hospital. So you might say all of the patients I've seen over the last 3 years are my population. So you may have a definition of that kind.
Okay, well, let's try to put this in some perspective here. Naveen, you're the medical director for accountable care. Now that term, I think it needs to be explained a little bit. What is accountable care from your perspective?
We use the term population health and accountable care, again, synonymously. But accountable care really means that the hospital or the doctor has taken some financial accountability for the outcomes that they're expected to produce. For example, I used the example of diabetes. So in addition to just seeing a diabetes patient, if I take accountability for making sure that most of my diabetes patients have achieved their hemoglobin A1C goal or their diabetes control goal, then I'm taking accountability for that. And if I say I'm putting my money on the line, the amounts I get reimbursed, if I'm putting that on the line in achieving that quality, then that's considered accountable care. And that outcomes could be the quality example I just gave you, or it could be a financial outcome, or it could be a patient experience outcome.
Okay. So getting paid, I think getting paid is a topic that's of interest to everybody. How does a physician approach population health as opposed to a fee-for-service basis? And if you were to arrange a population health environment and you like to see that value-based process in place, I've seen some situations, I think, where even though capitation is taking place, that is a fixed dollar amount for each person, the conveners out there, they still put forward a payment fee for service. It's kind of like, yeah, we're doing population health, but we're still paying you fee for service. Unpack that a little bit for me. Let me understand how that should work and how it does work today.
Yeah, I think you're highlighting a very important point that we could have all of the value-based care or accountable care models, but unless it reaches the frontline people who are providing that care, the incentives may be misaligned. So what happens today is while we have accountable care models, sometimes there are entities created to take that accountable care risk. So the entities take the accountable care risk, but they don't pass on that risk to doctors or some end delivery organization, and they just pay them fee for service like today for various reasons, convenience, to get participation, etc. But the fallout of that is the incentives are not aligned. So the people who are in the front lines who are providing care are incentivized differently than the people who are signing these accountable care contracts. So it makes it difficult to achieve the outcomes you want to achieve.
Okay, so let's take it home to UCLA, your environment there. How does population health work? You're in an academic medical center. You've got a number of different payers. How do you coordinate all of that with these different payers? What's the high level view of how you manage a complex environment like that?
We have a managed care organization. It's our UCLA medical group. We also have an Office of Population Health and Accountable Care, which I'm part of. And we work with our payers on the types of contracts I mentioned, alternative payment model contracts with the goals of cost and quality, utilization, and patient experience. And we coordinate that type of care within the health system. We work with our primary care doctors, our specialists, and our departments, and constantly try to redesign our care for the new paradigm.
So when you talk about these alternative payment methods, I got to invoke the word risk here. Okay. Do you take on full risk for taking care of those patients, or is that a shared risk? I've heard some people talk about population health as, like, for example, on a previous episode, we had Dr. Gordon Chen with ChenMed, and he provides, value-based services to a very specific targeted population with 500 patients in a panel. And you probably have 5,000 or 10,000 patients in a panel. He takes on the full risk in that environment. Would you do that with a large population? And if you do, I'd like to know, how do you go about calculating that risk ahead of time?
We don't have 5 or 10,000 in a panel. It's much, much more reasonable. Yes, there are different gradients of risk that a health system or a physician can assume in an accountable care model. So you gave an example of an organization that may take full risk, but we take risk along a spectrum. So there may be situations where we just take risk for professional services, meaning services other than hospitalization, or we may take risk in a manner where we take the full risk for the entire population, including professional services and hospitalizations. Then there could be bundle payments. CMS, or the Centers for Medicare and Medicaid Services, Medicare, has lots of models, and one of those models is called bundle payments, where we get paid for a bundle of services, if you will. So we're participating in the joint replacement bundle. So they look at the total cost of care for that bundle against a target and see how we do. So there's a range of models that one can participate in, and we participate in a number of these types of models.
Yeah, Dr. John McCracken said that CMS they have so many programs, it's like feeding popcorn to pigeons. There's just a tremendous amount of different offerings that come from the Center for Medicaid and Medicare. These programs are frequently being introduced. Do you see any that are more effective than others? This concept of bundled payments, is that one that you guys use at the UCLA environment?
Yes, we participate in the bundled payment services. We also participate in other programs that CMS has. Primary Care First is another one that we just started participating in. So there are a number of services that we participate in.
I'm really interested in, we kind of talk about the history of how population health got started. And I know that CMS was part of that, I believe. They started introducing programs, started introducing value-based, pricing and value-based services. And with a lot of these programs coming out, I'm really interested to see how different organizations, like, how did you guys at UCLA decide that population health was going to be a good thing to do and it made good sense? And I know that your background, Naveen, that you specialize in the concept of informatics. And informatics really deals with a lot of data. And I think a lot of data that gets harvested helps you make better decisions. So kind of give us the history and background of how you got it started where you are today and how other people might find a similar approach that might work for them.
Yeah, mine is, I think, an interesting evolution of career. I was in private practice for some time. And during those years, I had my population of patients, if you will. And I was working really hard, all kinds of hours of the day and night, going to the hospital, going to my practice, and staying late at night before I came home, was hardly able to see my family. And during that time, I went through a phase of questioning myself, like, I'm working so hard, but am I achieving anything? Am I really helping people? I mean, it would be worth it, right, if I'm helping people, but I didn't know that. Because they come in, I give them medication, I give them advice, and I send them home, but are they really getting better? Like, I treat arthritis as a rheumatologist, and lots of these patients are young women with rheumatoid arthritis, and I give them medications, sometimes toxic medications. And you wonder, did they get better? Did they regain function of their hands? Were they able to go back to work? Were they able to take care of their families? Were they able to have a social life? And I didn't know. So I was thinking, hey, here, I'm a young doctor, and I should know this before I commit my whole life to doing this. So I decided to find out. And that was through putting in an electronic health record system in my practice, gathering data of my patients to understand, am I making a difference? And so that is really, in essence, analytics, to understand what effect you're having, whether you're achieving the desired outcomes. And so I was doing that for a number of years. And eventually I ended up being the Chief Medical Information Officer for City of Hope. Along the way, I was also co-founder of a startup company. And at City of Hope, when we put in the electronic health record system, there was an ocean of data that flowed in. Then what do you do with all that data that flowed? So we built data warehouses and looked at reports, dashboards to see how our care was, or were we achieving the goals that we wanted to achieve. And then tuning the business, tuning our healthcare processes to achieve the outcomes. That's redesigning healthcare. So when you're doing all that based on analytics, changing healthcare, that is informatics, but on the flip side of that, it's also population health because you're trying to improve the health of populations. So they're really two sides of the same coin, but over time, I sort of gravitated towards this side, which is population health.
So informatics is the secret sauce. Getting your electronic record healthcare system, your EHR in place, gave you the data. And CMIO, the Chief Medical Information Officer, that was an evolving new term for a new role. And I guess early on, it was gathering data.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
Tell me about CMIO 2.0. What follows once you get all this data?
Yeah, so as you know, there are chief medical information officers who help implement electronic health record systems for hospitals, and they help enhance them, tune them to improve the care that I was talking about. And then the early version of the chief medical information officer, their main charge was to put in these systems, get the transformation from paper to digital, have electronic systems. But once you have the electronic health systems, you have to use them. You have to use them to improve care. That use to improve care and achieve health was sort of a different flavor of a CMIO. And that type of CMIO was focused on population health and quality, achieving patient experience, cost, etc. And so that new next generation of CMIO is known as CMIO 2.0. It also has another name, Chief Health Information Officer. So you can see how we're all talking about the same goals, but we're coming at it from different perspectives. So I tend to think of it this way. We're all trying to achieve population health, but the population health is powered by informatics, by analytics, and by the work that the chief medical information officers do.
Well, I think your testimony there, Naveen, is pretty significant, that you wanted to find value in being a physician, and you wanted to do that by finding value for patients and for your population. So the kind of two sides to that coin as well, finding a way to make a difference. And, today, physician burnout is a big thing. People are not practicing at the top of their license. They're doing more administrative things and not really focusing, on the patients and their population. And that really brings up a concept. I mean, seeing it from the physician perspective, let's look at it for a moment from the population perspective. I'll call it the patient. Maybe patient's the wrong word. Maybe everybody doesn't have to be sick to be involved in population health. There's a health dimension of this which can be expounded upon, where we focus more on health instead of illness, focus more on wellness instead of illness. And the social determinants of health, how does that fit in? Taking care of a population, boy, I would think I've heard it said that maybe 20% of your health equation is seeing a doctor, and the other 80% have to do, with the social determinants of health. How do you invoke that social determinants of health element into a population health environment?
That's a great question, Bob. And as you said, we're realizing more and more that the health of a person, is determined largely by their background, their environment, their experiences at home, if you will. Not so much what the doctor does or what the hospital does. The impact of what the doctor and the hospital does on overall health is probably quite small, unless if you're really sick and you need immediate treatment. So the health, as you said, is determined by what we call social determinants of health. That means all the things that influence you at home: food, access to good nutrition, good relationships. People are socially isolated, for example. That has a negative impact on their overall health. Behavioral health, like depression, those kinds of things can lead to deterioration of overall health. And there's also very fundamental things that people don't have which can affect health: transportation, housing, overcrowding, lack of open spaces. So all of these things together we consider as social determinants of health. And yes, while in the healthcare system, we're focused on the medical aspects of care: medications, surgeries, education, those kinds of things. We're also beginning to focus on the social determinants. Even though we're health systems and even though we're physicians, we're focused on that. We ask people about all of the things I just talked about. And when we know the full picture of a human being, then we can provide better care. So I think of a hospital or health system asking about social determinants as getting the full picture of a person. I want to know your whole story, Bob, before I treat you. I want to know what's driving your health. And once I understand that, I can address that.
Well, that's the key element there. Face-to-face, eyeballs, looking at people, talking to people, not so much looking at the computer all day long, but actually, asking someone those important questions. Do you see a process in place that may reduce the variation or even the overuse of healthcare? With this informatics that you start to gather, can you find that you might not have to do certain things that you would have done not knowing the information? Is informatics playing into the social elements as well? All this data that you might want to know about their social environment, is that part of the informatics gathering process too?
Yes, gathering the social determinants of health and the whole history of a person is part of population health, is part of the healthcare we now provide. And we use that. Our challenge really is to really start using that to drive improvements in care, either to hold and support patients in addressing their social determinants, or we providing some help in addressing those social determinants. So yes, that's a very big component of that. And in informatics, if we can capture all of these data elements in informatics, we can tie that in to what is happening medically, and we can tie that into the outcomes you want to achieve.
So one of the things that we talk about is, the initial visit with a patient, whether they go to the hospital, they get treated or whatever, but the transition of care all the way to the home. Is that part of population health as well? You said you like to know everything about everybody and take care of them. Talk about the transition of care that you can invoke with a population health environment.
Yes, one of the difficulties we have in the current systems is that we're not so good at handoffs. When a patient makes transitions between hospital to home, or make transitions from hospital to skilled nursing facilities to home, those types of transitions, we're not so good at handling, and things get dropped. So our focus in population health is to retie those connections, strengthen those connections. So there is no gaps in care. So when a patient goes home from the hospital, we have to be there the very next day to make sure that they understand what they're supposed to do at home. Because for a patient leaving the hospital and going home, most of the time they don't remember what they may have been told, or at least not the details of what they've been told. So it's our job to be there for them and to remind them, to support them in having a successful transition. So we consider this entire continuum of care, as it's called, a proper domain for population health.
So the academic medical centers, I think each of them have a program, maybe at different degrees of activity related to population health. I know that's a starting place for population health. What about the individuals, the smaller practices, the smaller groups, the hospitals and things of that nature? Are they embracing, from your opinion, this concept of population health as well?
I think it may be slower, but I think it's definitely being recognized and adopted across the whole spectrum of healthcare. As I said, in some places faster, in some places slower. But I think there's definitely increased recognition that these things are very important. Social determinants and transitions of care. There's a focus by all of the quality organizations that we participate in on these types of things. So we tie up all our loose ends and we take a good comprehensive look at our patients as a whole person and provide the care they need.
Well, we're all seeing things differently now, Naveen, with the epidemic that we've been through the last year, and it's worldwide, as we know. And it's affected a lot of different dimensions of healthcare, both from the patient perspective and from primary care and hospital utilization, et cetera. Do you think that the concept of population health will change after the pandemic?
I believe so. Population health has become much more important. Keeping people out of the hospital, preventing disease, things that we've always been focused on in population health has become even more important. Now we're talking about the vaccination for COVID-19, but we've had a focus on all kinds of other immunization for a long time. And now we may have more awareness on prevention, cancer screening, for example, immunizations, achieving control of your diabetes, your blood pressure. Those kinds of things may take on a lot of prominence. And also the very method of delivering care could change. We're using a lot more video visits, telehealth. Virtual visits have increased tremendously across the country. And that's not going to go back to where it was before. And home as a venue of care is going to become more and more important because the patients, the consumer, if you will, wants care on their terms, not on the terms of what's convenient for the doctor or the health system. They want care at home. If I'm a busy person going to work and my child has a rash, I may just want to take a picture of that and send it to my pediatrician. Why do I have to take a day off? Take the kid out of school, drive across town, park, pay for parking, wait in the waiting room, for the pediatrician to see that same rash. So the convenience of care will improve as a result of the pandemic.
Well, I think I've heard a lot of doctors say, I wish that the patients cared about their health as much as I do. And a lot of patients don't. A lot of patients have not been actively engaged in things like nutrition, rest, activity, some fundamental elements of their health. But what I do believe is happening is that the more you get exposed to your healthcare environment, whether it be through telemedicine or through the social determinants, the more activity you have, the more mind share you have, and the more cognizant you are of your health and what you should be doing. And little by little, I think the patient starts to care about their health just as much as the doctor might be caring about the health. So I think that's a really important component there. And as we can facilitate more education, patient education about some of the fundamental elements of a healthy life environment. And part of that, just we see today that there's a reluctance in some cases for getting the vaccine. And I'm grateful. I've had both of my vaccine shots. I'm very grateful for the fact that the scientists were able to create and deliver and make that available. Have you had your vaccines as well?
Yes, I've had both my shots.
Yeah, I'm a big advocate of it. I'm still going to mask up when I go out to public, but I want to encourage people as a public service announcement to embrace this, and collectively every time somebody gets the vaccine, it really helps minimize the spread of the virus, and I think we'll get this thing under control in a more productive way. At least I'm very hopeful of that.
Yeah, isn't it amazing that we have something that can actually help prevent this terrible disease? We actually have something, the vaccination. So when it's made available to you, why not take it? It's very safe. It's very effective. Something that we had not imagined a year ago, that we would have such a safe and effective vaccine. We do. So when the opportunity comes, I think it'd be great to accept it.
Well, I know we're in for a lot of change in healthcare. There's a lot of technological disruptions. The advancement of these electronic health records, the informatic data, being able to get in front of these problems ahead of time with data is a magnificent thing. And I salute you and what you're doing there in your role, and appreciate your physician leadership and the promotion of these concepts and ideas. So it's a great pleasure, Naveen, to have you on the Business of Healthcare podcast. So thank you for joining us today.
I enjoyed it very much. Thank you so much for having me.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.